Thank you.
Thank you for being here. Thank you for being here. My name is Mary Ann Fairbanks, and my question is something specific that I've seen. When it comes to services, especially like surgeries and things like this that doctors do, they're not always the same. There's, children born with birth defects, and everything doesn't always look the same. And I'm concerned that it's always the insurance companies that have the bottom line say in how long the patient's in the hospital, how much they're going to pay for it, rather than the doctors saying, this is what's so, and this is how long this patient, in my opinion, this particular case needs to have and what they need. And, what's happening that you can see that can really go back? Because right now the insurance companies are running the show. What's happening that can go back to have the doctors have the say? Thank you.
I think to the extent we take out of the system the things like the lifetime cap on benefits, the minimizing the $10,000 out-of-pocket, putting a cap on the out-of-pocket expenses that any member has, any covered person has to pay in a given year, the capacity to drop people because they become too expensive. As you start to take some of those perverse incentives out of the system, then you give more leeway to the doctor and the physician, the doctor and the patient to make choices, rather than the insurance company that's looking at, we're only going to spend this much on so therefore let's cycle people through rather quickly rather than taking the time that's actually needed. But right now, there's so much focus on profit and so much, and in driving that profit, so many constraints on physicians and tying the hands in so many instances of the patient that I think as you start to initiate and put those insurance reforms in place, you will see some of that dynamic change.
As a senior who uses Medicare and who paid into it for a lot of years before I turned 65, the most pernicious part of this plan, I think, and the most under-publicized, is that you and the President plan to pay for it, 40% of it, by cutting Medicare benefits. You plan to take about $500 billion out of what Medicare spending would have been otherwise. Medicare reimbursements are already too low. When I had coverage from my employer before I retired and went on Medicare, my cardiologist saw me twice a year. Last year when I went in, he said, "Dave, looking at your blood test numbers, I think I only need to see you once a year." I think that had a lot less to do with my blood test numbers and a lot more to do with low Medicare reimbursements. And if you and President Obama have your way and cut Medicare further, the next time I go into my cardiologist, he's going to say, "Dave, these blood test numbers are great. I don't ever need to see you again." I think if you make these cuts in Medicare, seniors are going to have a very, very hard time getting a specialist even to see them. When they go to the hospital, they're going to lie in a gurney for hours because any hospital with a brain in its head is going to take the private insurance one that reimburses the hospital at a decent rate before they put a bet into the position of a Medicare patient who gets reimbursed at a lower rate. I think this is one of the most under-publicized part of this whole debate, is to take $500 billion out of Medicare. Now, I know you and the President say there are inefficiencies, and I think in one of your letters you used the term value-based purchasing, which talk about a code word for steep cuts. I think that's it. I hope that seniors will come to realize just how degrading to their health care these cuts are going to be, and that they fight this thing tooth and nail, and that we not pass it, because seniors deserve a lot better than the kinds of cuts you're talking about, and the efficiencies aren't there. This is going to be real, honest-to-God cuts that degrade the quality of health care that seniors get.
There are significant savings achieved through Medicare. One of the primary sources of it is a program called Medicare Advantage. I don't know if that's a program that you have, but it absolutely, in that instance, we are reimbursing at a 14% higher rate those who are enrolled in Medicare Advantage at a 14% higher rate than we do through the regular Medicare program. That is an area where savings can be achieved and also create a fairness across the system. So I don't know if that's what you're focused on, but that program is clearly one that we are focused upon as a way to achieve savings. But there are other things that are of benefit to them, and if you're in a Medicare Advantage program, that is something that you may find you may not be happy with or content with. There are other reforms that are across the board help assistance to people. The donut hole is one we hear about all the time. You have now Medicare Part D, which covers your pharmaceuticals up to a certain point, about $2,600. You drop into a donut hole where you are responsible for all your whatever drug costs you may have until you come out of it, I think, at about $6,000 or $7,000. And many quickly arrive at the $2,600, but often never come back out of it. President Obama, in his agreement, in his negotiations with the pharmaceutical companies, they agreed that they would control the cost of their drugs so that people did not hit the donut hole so quickly. That is step number one. Step number two is that over time, the donut hole is going to be phased out because it is very costly, and we have to find a way to pay for it, but we also understand how important the many drugs are that seniors need. If for no other reason, many instances, they are a wellness issue as well. So they help manage chronic illnesses and lots of other things. The other issue we have is the reimbursement rate for Medicare physicians. There's a targeted cuts to the reimbursement rates that every year we in Congress have to fix. We're fixing it in this legislation for a time being, but long term we have a bigger challenge we have to face. We have to come up with the funding to fix it long term, but we want, and the goal of that is to keep Medicare providers in the system so they don't threaten to drop it as their reimbursement rates go down. So those are the issues, those are the features in it that are focused on Medicare, and in addition, eliminating many of the preventive services copays that for some people can be quite a burden in order to encourage people to get, as I talked about, flu shots and all the other, routine exam, all the other things that will keep seniors well and not be an obstacle, have the copays be an obstacle to seeking out that help.
First, I want to identify myself. I'm a Democrat, and I'm against the Obamacare plan, and I don't like being referred to as a right-wing extremist or a part of a mob. Nobody paid me to come here, and I came on my own volition. Number two, seniors take notice. $500 billion taken out of Medicare or more. In your own words, a little while ago, you said Medicare is currently a challenge to the federal budget. For a program that's currently a challenge to the federal budget, to then have at least $500 billion taken out of it, seniors take notice. Number three, I also think that people should be aware that really there is no commitment to checking people who aren't citizens. Somebody covered that. So even though in the bill they say that people who aren't citizens, and by the way, they make up a large majority of the underinsured that this whole program is all about. And given that they're saying they don't cover them, but there is nothing in the bill that asks for identification.
people take notice. There's a lot of things in this bill that aren't mentioned by the politicians, and you ought to read them. And I have a question. The Massachusetts plan, apparently, is a good example of a plan that has worked pretty well. So I would like you to comment on currently why Boston Medical Center is now suing the Commonwealth of Massachusetts.
The Massachusetts plan has been a very good system for bringing people into a connector program where they have access to insurance they can afford, and in many instances it is subsidized by the state in a tiered way depending upon people's income level, and then it is phased out at some point. It's also a pooling mechanism for people, self-employed people, to go and find more affordable insurance than they might find if they were going out into the market on their own looking for an insurance company. So as a result, it's led to over 500,000 people now having insurance that did not have it. The issue that you raise is a reimbursement rate for hospitals. The thought was that as more and more people have insurance, we're resorting less to care in the Boston Medical Center, for example, through the emergency room, but rather we're coming in through care that was paid for through their insurance policies, that there would not be the same need to make certain payments into those hospitals that really do provide care for those who, from particular neighborhoods where they are particularly reliant upon subsidized health care. That has not proven to be the case to the degree that was anticipated, and so that is something that is currently being revisited at the state level. It's very much an issue as we talk about this in Congress. How best to protect hospitals that serve underserved populations or inner city populations, and to make sure that they are not overly shortchanged, especially in the transition as we go from the uninsured, more and more insured, getting covered, their care getting covered through insurance policies. There's still a dip and a time in which we're going to have to be very mindful, because these are important resources for the community and for people seeking care. There's a lot of discussion around how to address reimbursements for hospitals in different parts of the country. Rural communities have particular challenges. Inner city hospitals have particular challenges. It's one of those moving parts as everybody's making the case for what their particular communities need.
Hi. Thank you and the rest of Congress for being willing to stick your heads up out of the herd of lemmings heading for the cliff and saying, we can't let the status quo drop us all to doom. Now, you gotta make changes, and any changes that are made are going to have strenuous, heartfelt opposition from honest, caring people who really believe that they are wrong. Any of them. I'm really reassured by what you've told us here today that you're on the right track, and I appreciate it. But I would like to know that you are committed. Are you committed to making sure that the bill, whatever bill that passes, has a strong public option?
I'm very committed to a public option. We are making the case and working in a concerted fashion. We have a long way to go. It's in the plan that the House is putting forth. It remains to be seen what is put forth on the Senate side, and then it remains to be seen what comes out of conference. But I am relatively confident that whatever legislation comes to the floor is going to have a public option that can compete with private insurers and provide people a choice.
And will you also commit to vote in favor of H.R. 676?
What is that?
They're not exclusive. It's a single prayer bill.
I'm committed at this point to moving forward the agenda that we have. When the single-payer bill comes to the floor, I'd be prepared to talk with all of you about it and make a decision at that time.
Yes. You touched on this before, but I'd like to bring out a point. If 47 million uninsured people are added to the patient base, where are all the new doctors, nurses coming from? We are already experiencing shortages in Massachusetts. My wife tried to see her gynecologist with the problem, and she was told that it would be a 7-month wait. This never happened before to her. The universal coverage in Massachusetts, this never happened to her before the universal coverage in Massachusetts came into effect. If justice delayed is justice denied, is health care treatment delayed, is health care treatment denied? In essence, the Massachusetts health plan that is currently in the state, and the one in Tennessee, which is similar to the one in the state. What happens when the government tries to model themselves after the same type of insurance plan that now is driving Tennessee and Massachusetts into bankruptcy?
There are a lot of questions in that one question. So, to go with the challenge that the Massachusetts system has had, it's twofold. You're right. There is not the numbers of primary care physicians that are needed to absorb the many people who are coming into the system for care. And that is a challenge that this legislation recognizes and has a whole section devoted to, as I was talking about earlier, encouraging people to go into primary care fields, but also all of the other practitioners that are needed. So whether it's nurse practitioners, whether it's public health officials, doing much to encourage that. The other thing is there is a significant investment in community health centers, which are an important resource in the inner cities in particular, where you have people who need access to health care. But it's a larger issue, I believe, than just Massachusetts. And it's one we have to look at very seriously because, for example, there aren't necessarily enough doctors being trained generally to serve the needs of this country. And the medical schools in many instances are too small to suddenly ramp up and begin to turn out more physicians to address generally the challenges we have. I don't think this bill alone is going to make that more complicated. It's just something we have to acknowledge generally. It's an important one. Massachusetts, yes, we have suddenly had to, when the Massachusetts system was put in place, the strategic decision was made to create access to health insurance by creating a connector program that either subsidizes those who can't afford it outright and who meet certain income guidelines, or to come into the connector to choose private insurance plans if you're a small business or self-employed and simply want to look for a more affordable health insurance plan. We did not deal with the underlying issue of the cost of care, which is why recently there was a commission that has studied this matter, has come forth and saying we have to begin to visit how we're paying for health care, not so much how the insurance dollars in it, but the cost for the physicians to deliver services, the cost for hospitals to deliver services, what is happening there that is driving up the cost of care in a way that we cannot absorb. And that is where you get to looking at things like the way in which we reimburse physicians. So if we reimburse a doctor every time they deliver a service, that doctors are human beings, and they're going to maybe, have more office visits, ask for more tests, because they get rewarded every time they do it. So instead, look at a more holistic way of paying for patient care. That is just one option on the table. Electronic record keeping is seen as a very potentially effective way to reduce costs. That can be done on a statewide level, but it's more effective if it's done nationally. And also the resources that are needed are very intense, which is why in the American Recovery Act, we made a down payment and make monies available for electronic record keeping. That's where we get back to the comparative effectiveness data. So you have a repository that people can look at and say, all right, how do we deliver care and keep people, do the best by people, and not just operate sometimes in the dark. So you go, you look at that, the patient looks at it, the doctor looks at it, it's objective data, you analyze it, and the doctor and the physician together make a choice as to what is the appropriate step forward. There's nothing easy about it. It's very personal, and I think the reforms try to respond to that, to the fact that people are so concerned about this, but to also acknowledge the global issue we have, which is, as a nation, we are spending almost 3 times as much on health care as other developed countries. And there have to be mechanisms for getting a handle on what is driving that fact that we are so much more expensive in the provision of care. Yes, we provide great care when people are really ill, and we never want to lose that. We never want to lose that. But there may be steps along the way where we could be doing a better job than we are.